serta ramah terhadap teman-teman difabel dengan menyediakan jalur khusus hingga fasilitas umum. Tak lupa, ramah juga terhadap ibu hamil dan menyusui maupun yang sedang sakit. Di luar kegiatan akademik, program studi Magister Kesehatan Masyarakat Universitas Diponegoro juga mendukung mobilitas mahasiswa dengan fasilitas sepeda kampus serta pemberian pengetahuan dan keilmuan yang dikemas secara modern melalui channel podcast.
Kami dalam hal ini termasuk rumah sakit pendidikan di Undip dan sudah menyelenggarakan berbagai macam aktivitas pelayanan dan termasuk pendidikannya. Kami menyediakan juga untuk MIKM mahasiswanya untuk bisa melakukan residensi, magang, dan juga kalau perlu nanti bisa kami rekrut di Rumah Sakit Nasional Diponegoro.
Proses belajar mengajar serta kurikulum yang komprehensif ditambah sharing alumni Magister Kesehatan Masyarakat Undip membuat saya semakin paham bagaimana harus mengimplementasikan ilmu manajemen rumah sakit dalam praktik sehari-hari sebagai Direktur Medik dan Penunjang Medik Rumah Sakit Santa Elizabeth Semarang.
Saya bersyukur dan sangat bangga sebagai alumni Magister Kesehatan Masyarakat Undip peminatan administrasi dan pendidikan kesehatan. Proses pendidikannya sangat menarik yang didukung dengan fasilitas sarana prasarana yang sangat menunjang maupun dosen yang sangat kompeten merupakan area penunjang keberhasilan kami dalam menyelesaikan pendidikan.
Mari bergabung dengan kami program studi Magister Kesehatan Masyarakat Fakultas Kesehatan Masyarakat Universitas Diponegoro.
Buka dulu nih.
Halo, Assalamualaikum.
Waalaikumsalam. Waalaikumsalam.
Nggih. Suara cukup jelas?
Jelas.
Oke.
Ya. Mikael sudah sumbernya. Prof. Marta sedang melihat narasumber. Dokter Mikael lainnya sudah bergabung.
Suaranya Bu Cahya menggema.
Saya Prof. Marta, Prof. Marta, Prof. Mursid. Ini Prof.
Iya,
Marta lagi menunggu Dokter Mikaela.
ya ini suaranya Bu Cahya menggema. Satu device saja.
Baik, selamat pagi. Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera
Waalaikumsalam.
buat kita semua. Ya, pada pagi hari ini kita akan mendapatkan tamu, mendengarkan guest lecture ya dari eh, the University of Queensland academic staff, yaitu Michaela Wheeler, yang akan Dr. Michaela Wheeler yang kebetulan saat ini sedang ada problem sedikit, yaitu ada fire alarm yang nyala di gedungnya, sehingga beliau dievakuasi di luar gedung dan berharap berharap jam satu jam satunya sana bisa tepat masuk. Ya, jadi atau jam satunya sana itu berarti jam 10-nya kita ya. Ya baik, kita mulai saja ya Pak Mursid, silakan mungkin bisa membuka acara ini dengan memberikan sambutan. Terima kasih Pak Mursid. Prof Mursid,
Lah, Dokter Mikaelanya belum ada gimana?
enggak apa-apa. Nanti kita berharap pada
Mm-mm.
saat yang tepat beliau
Oh
akan masuk.
iya,
Ya,
ya
ya.
kalau pesertanya kita-kita ya saya antarkan pakai bahasa Indonesia.
Iya, nggak apa-apa. Bahasa Indonesia. Nanti, ya,
Meskipun sudah disiapkan teksnya sama Bu Cahya.
ya.
Lagi-lagi mana? Kita tunggu dulu. Ya, percuma pakai bahasa Inggris, audiennya bahasa Indonesia semua. Atau tunggu sebentar.
Ya, oke. Baik, kalau Prof.
Hmm,
Mursid berkenan menunggu sebentar ya. Baik,
ya,
tunggu beliau kalau sudah masuk, saya akan mungkin beri tanda ya supaya saya memang memberi eh, tahunya Dokter Michaela supaya
Hmm.
nanti dia masuk langsung apa langsung kuliah begitu.
Oh gitu.
Apa Pak? Iya.
Oh ya udah kalau langsung masuk kuliah saya antarkan pakai bahasa Indonesia ya biar jelas ya.
Ya, ya, enggak apa-apa.
Ya, ya, ya,
Ya,
ya,
ya.
ya, baik ini atas permintaan khusus. Terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Ya nanti salam saya buat Dr. Mikaela ya, Bu Marta.
Ya,
Yang saya hormati ini moderator utama kita, Prof. Marta, Bu Ayun, Bu Cahya, semua teman-teman semuanya yang saya hormati, teman-teman dosen dan mahasiswa sekalian yang saya eh, banggakan ya pada pagi hari ini karena narasumbernya yang orang Australia belum hadir. Kami antarkan sebenarnya sudah disiapkan Bu Cahya dengan pengantar tentang bahasa internasional ya. Tapi karena posisinya semuanya audiennya Indonesia ya kita antarkan saja. Ini sebenarnya program-program seperti ini merupakan rangkaian yang di kita dalam rangka untuk mendukung Undip yang akan segera masuk di 500 besar dunia ya. Banyak program-program yang kita kemas, kita create ya. Ada ajang profesor, ada student go internasional, ada visiting lecture, ada international faculty, international research network dan kawan-kawan ini banyak sekali. Nah, pagi hari ini itu juga dalam rangka dalam upaya untuk bagaimana networking secara internasional itu bisa mendukung ya terkait dengan world class university ini. Saya selaku pimpinan FKM mengucapkan terima kasih sekali kepada Magister Kesehatan Masyarakat, Bu Ayun, Bu Cahya, dan seluruh pendukung ya yang telah mengemas acara ini. Dan bagi mahasiswa sekalian ini adalah pengetahuan yang sangat baik ya kalau yang sekelas naskah yang diberikan oleh Bu Cahya ini adalah bagaimana dengan menyikapi 12% penduduk Indonesia yang sudah masuk kategori usia tua ya, dan suka menyendiri. Dan itu adalah tantangan besar. Seperti saya dan Prof. Marta ya, suka menyendiri dan kategori orang itu. Dan ini mestinya ada kebijakan-kebijakan, strategi-strategi inovasi yang Dr. Michaela Wheeler ini kelihatannya pakar di bidang itu ya. Sehingga istilahnya silahkan aja itu dinikmati bersama, disimak bersama, dan jangan lupa ini karena mahasiswa S3 itu kan fluent dalam bahasa Inggris, sehingga istilahnya banyak interaktif ya, nanti Prof. Marta yang akan memandu acara ini, sehingga istilahnya terjadi interaktif yang jelas. Kemudian titip salam Prof. Marta untuk Dr. Mikaela, barangkali nanti mau berkunjung ke Undip ya, itu sangat terbuka bagi kita untuk bisa menerima beliau secara langsung di sini ya nanti dicarikan anggaran-anggaran ya Bu Cahya tabungannya banyak. Nah, sehingga nanti bisa untuk kegiatan-kegiatan yang seperti ini ya. Sekilas itu dan saya ucapkan sekali lagi selamat untuk berdiskusi terkait dengan tema besar ini dan harapan kami ada asas kemanfaatan terutama dalam jejaring internasional. Dan atas izin teman-teman sekalian, Bu Marta, Prof. Marta, Bu Cahaya, dan sekalian, acara ini secara mewakili Pak Dekan yang sekarang kebetulan sedang wisuda, kita buka dengan bacaan Bismillah bersama-sama. Bismillahirrahmanirrahim. Selamat berdiskusi untuk kegiatan ini. Matur suwun dari saya. Assalamualaikum warahmatullahi wabarakatuh.
Terima kasih sekali sambutannya Prof. Mursid, ya
Hmm,
selaku Wakil Dekan 2 yang
hmm,
mewakili Pak Dekan
hmm,
eh, FKM Undip. Ya, eh, sambil menunggu mungkin Pak Wakil Dekan mungkin berkenan memberikan
hmm,
pesan kepada mahasiswa mungkin untuk dalam
hmm.
eh, apa melakukan aktivitasnya supaya cepat lulus. Mungkin ada saran-saran dari
Oh ya,
Sid ya,
ya,
supaya semua ini mahasiswa
enggak,
S2 dan S3 itu juga
enggak,
em,
ya,
dia terpacu untuk
enggak.
memberikan
Ya, baik,
baiknya.
Prof.
Ya, baik.
Marta. Kami berikan terkait dengan garis-garis kebijakan di kepemimpinan kita ya. Kalau di atmosfer akademik yang kita ciptakan, sebenarnya seluruh upaya, baik itu dari sisi akademik, sarpras, dan sebagainya, semuanya itu adalah semaksimal mungkin mahasiswa ada kenyamanan, ada atmosfer akademik yang baik, ada terkait dengan hubungan internasional, ketersediaan jurnal, dan kawan-kawan. Harapannya apa? Itu semua adalah diperuntukkan dan digunakan oleh mahasiswa sekalian. Sehingga istilahnya harapan kami, kalau ibaratnya kita pabrik, itu produk-produk yang lulus itu seharusnya sesuai dengan target-target waktu yang sudah kita tetapkan. Sehingga istilahnya misalkan S3 ya kalau bisa lulus 2,5 sampai 3 tahun itu suatu yang sangat baik. Kalau S2 1,5 sampai 2 tahun itu hal yang sangat baik. Kalau yang S1 3,5 sampai 4 tahun itu yang sangat kami harap. Sehingga istilahnya memang semuanya itu kami berikan untuk mahasiswa. Dosen juga sudah kami wanti-wanti gitu ya, bagaimana kita bisa secara hospitalized ya memberikan pelayanan kepada mahasiswa, kemudahan akses, kemudahan komunikasi, sehingga istilahnya bisa mendukung mahasiswa untuk lulus sesuai dengan tepat kualitas, tepat waktu, tepat program dan sebagainya, termasuk pembiayaan. Perlu diketahui bersama, semakin kita melonjak waktu studinya, maka akan berimbas kemana-mana, termasuk biaya hidup, biaya SPP, dan sebagainya. Selalu saya sampaikan, banyak ya mahasiswa itu, ya tidak banyak, ada beberapa mahasiswa itu yang hanya membayar SPP tapi tanpa aktivitas. Itu artinya memberikan sedekah yang besar kepada Undip, karena membayar tanpa ada aktivitas. Ya sebenarnya kami terima kasih dibayari tanpa aktivitas, tapi bukan itu sebenarnya harapan kami. Sehingga istilahnya monggo nanti mahasiswa sekalian kalau ada apa-apa sampaikan kepada kami. Kalau ada yang tidak nyaman sampaikan kepada kami, termasuk ada dosen-dosen yang mungkin sedikit mengganggu sampaikan kepada kami. Ya itu harapan kami sehingga istilahnya bisa terjalin antara mahasiswa dan kami selaku pimpinan maupun pengelola. Barangkali itu aja, Prof. Marta. Saya ucapkan Prof. Marta, monggo nanti silakan memimpin diskusi ini, sehingga semuanya bisa berjalan dengan baik sesuai dengan target-target yang telah ditetapkan oleh Bu Cahya dan kawan-kawan. Ngeten nggih, Bu Marta, matur suwun.
Prof. Mursid untuk sambutannya.
Hmm.
We welcome Dr. Michaela Wheeler. Yeah, welcome. Good afternoon for you, Dr. Michaela Wheeler. How are you?
I'm good, thank
Oh,
you.
oh yeah. How
Yeah,
are you, Dr. Michaela?
yeah. Prof. Mursid is our Vice Dean for
Yeah.
yeah, the
Yeah.
second Vice Dean. Yeah.
Okay, yeah.
So
Okay.
you already welcome you actually, but
Oh, yeah,
Oh,
yeah.
yeah.
thank you very much. I apologize for being a few minutes late due to the fire
Oh,
alarm in my building.
oh yeah, doesn't matter for you, Dr. Michaela. And I will invite you to come to Semarang ya, to Universitas Diponegoro next time. Together with Prof. Marta. Please you come to Semarang ya, Universitas Diponegoro.
Yeah.
And I was open speech in this lecture, and please Prof. Marta to lead of the conference ya. Please Dr. Prof. Marta.
Yeah.
Hmm.
Thank you, Prof. Mursid, for being here, and welcome, Dr. Michaela Wheeler. We are very happy that you can give us the guest lecture. Yeah, the guest lecture is about on public policy and intervention to address social isolation and loneliness in older adults who live in the community. I would like to introduce Dr. Michaela Wheeler. Yeah, yeah, yeah. She
Thank
is,
you.
yeah. Can you see? Sorry, is it?
Yeah.
Yeah, okay. She is a lecturer in the School of Public Health and has clinical and research expertise as a dietitian nutritionist in residential aged care and community setting. Using mixed method and co-design methodology, her research focuses on improving the lives of older people through system design to tackle imminent problems, including poor nutrition, social isolation, loneliness, and specialist care for people living with dementia. In her teaching, Michaela delivers undergraduate courses in chronic disease and nutrition across the lifespan, and is part of the advocacy and public health teaching team in the medical program. Yeah, that's a short CV. Now, please, Dr. Michaela, could you present? Yeah. Thank
Thank
you.
you very much for that introduction, Martha, and thank you very much for having me. It's a privilege to present to you all today. I will share my screen and get started with the presentation. Sorry, let me just. Just having a little bit of difficulty here. There we go, and then hopefully you can see my presentation now. Perfect.
Yes, thank you. Dr. Michaela, we can see your presentation.
Great.
Yeah.
Thank you very much. So today I'll be talking about, like my background said, I'm a dietitian and nutritionist working with older adults, but more broadly in the past few years have looked at different components of health and well-being for older adults. And one of these areas is social isolation and loneliness and how that impacts our community. Before I would begin, I'd like to acknowledge the traditional owners on the lands on which I'm joining you from today. That's the lands of the Yagara and Turrbal people here in Brisbane, Australia. I'd like to pay my respects to their ancestors and their descendants who continue cultural and spiritual connections to country and recognise their valuable contributions to Australian and global society. I don't need to do too much of an introduction because Martha's already done a wonderful job of introducing me. So I'm going to jump straight into the presentation today, which is focusing on the policy around social isolation and loneliness and how it exists in our community, and then going to look at a specific intervention, an example that we ran over the past 2 years to try and reduce social isolation and loneliness in our community. If you have questions, again, please pop them in the chat as we go along. The issue of social isolation and loneliness is quite significant, particularly here in Australia, but it's globally as well. There is a lot of attention from media, from the community, and from governments as well around social isolation and loneliness. Who become socially isolated? Is it older people? Is it younger people? And how do we actually reduce this in our community, particularly because of the impact that it has on health? So it's a very topical area at the moment. I'd be very interested to hear if it's very similar in your setting as well at the moment. It is an important area globally as well. So the World Health Organization, you may be aware, we are in the middle of a UN decade of healthy aging. And that decade of healthy aging has a whole wide range of areas in which there should be impact around the health of older people, from nutrition to psychosocial health to mental health, physical health, social health, a whole range of areas. But what the World Health Organization and the Decade of Healthy Aging have really clearly stated is that there is a widespread feeling of social isolation and loneliness in older people. So we can see in some countries 1 in 3 people, so it's quite prevalent. And we know that there are really negative impacts on people's well-being and their health. So they live shorter lifespans, it damages physical and mental health, and it can reduce quality of life. And that makes sense, given that if people are socially isolated, they may have care needs or health needs that are going unmet. And if we even think back to ourselves, when the connections that we have with our friends and our family and our community, if we're not able to make those connections and continue those relationships, that negatively impacts our mental health, and that increases the risk for older adults as they age, and there is more morbidity associated with that advancing age. Some of the things that the World Health Organization has noted that we can do to improve this is actually improve or increase political commitment. So social isolation and loneliness isn't something that is always, it might be at the attention of governments, but doesn't always attract appropriate funding to support people to be socially active, whether that be through meeting their care needs or funding programs that facilitate connection between different people in the community. We also need to look at improving the research and evidence for what works. So from a preventative view, we need to look at how do we prevent people from becoming lonely or socially isolated in the first place? What can we do? And then when people do become socially isolated or lonely, what can we do then to help them connect back with their community and improve their mental health again? And we also need to look at scaling up effective interventions. So when we look at the landscape of research at the moment, many of the interventions that are completed are small, discrete interventions. They take place in small communities or a particular demographic of people. They're not those large scale studies. So we need to look at how can we actually scale those up to meet the needs of a broader population. And this is just some data from Australia. And we measure social isolation through a national health survey where we have a question that asks about connection. It's not a validated measure. I do need to make that clear. It is just the one question that we ask. But what it has shown is that older people here, when we look at older people, there is a percent that are socially isolated. Interestingly, when we look at the demographics, so these are the age groups here. We see older people have levels of social isolation and loneliness, but we're seeing a significant increase in younger people being socially isolated and feeling lonely as well. One area of work that is growing in Australia is the intergenerational connection and relationship. How can we connect these people that are in this 15 to 24-year-old age group with people who are in their 65 and plus, to try and create some of that shared understanding and sharing of life experience? But it is prevalent in Australia, and it's something that we are very aware of that we need to address. I wanted to provide a little bit of background on how we define loneliness and social isolation. So loneliness is an expression of negative feelings, of missing relationships, and occurs in individuals of all ages. So we've already seen that from the data that we see loneliness occurring across, but it's more so when people are unhappy with the level of social contact that they are having and have those negative feelings associated with it. And that can occur through a number of ways. There's also subsections or subcategories of loneliness. So emotional loneliness is when it's stemming from the absence of an intimate relationship or a close emotional contact or attachment. So this is like a partner or a best friend. And so when we see, particularly in older adults, if we see a partner pass away and become there's a widowhood or a divorce, that's when we can see quite significant feelings of emptiness and abandonment and increased risk of that feeling socially isolated and lonely. We also have social loneliness, and this is stemming from the absence of a broader network of contacts of engaging in social work. So these are your friends, your colleagues. They can be if people volunteer in communities or are a part of community groups, whether that be Bible study, we have exercise groups, all of that, all of those connections as part of your social connection or your social loneliness. And when we don't have those, this is where we see people's loneliness being impacted. For young people, if they're moving to new places, we commonly see them reporting social loneliness. And so social loneliness and emotional loneliness together can be measured to provide an overall loneliness score. And I'll talk a little bit about that later on. Social isolation, however, is more of an objective measure. So loneliness is very subjective. There is a scale in which people may feel lonely and different people perceive loneliness at different levels. However, social isolation is more that objective, measurable lack of contact with social connections. So what we can actually do is we look at a person and we count the number of social connections they have, and we can measure the number and the quality and the quantity of those social connections. The challenge, or one of the area of issues with social isolation, is that it isn't inherently negative. There are some people in the community who are socially isolated, who have very few connections, but they are very happy being a little bit more quiet and isolated. They prefer their own space and their peace and quiet. But there are some people who really like to be engaged with their community, and for them, it'd be very socially isolated is not a good thing. So whereas loneliness is always that negative measure, social isolation does not always mean it's a negative for people. And in the example that I'll give further in the presentation, this was we saw this quite strongly. So how do we measure social isolation and loneliness? This is by no means an exhaustive list. These are just some examples of tools that I've seen used in research and that we've used in our research. So social isolation, we've used the Lubbock Social Network Scale, the Social Provision Scale, and the Duke Social Support Index. The loneliness scale, I've used the De Jong Group Hold Loneliness Scale, but the UCLA is quite a globally popular tool. Some of the challenges with measuring, as with any health outcome, there are challenges in measuring these outcomes. So, from our experience in our research, working with older populations, it can be quite a challenge if the questionnaire is really long. So people struggle to fill out a really long questionnaire. There are some questionnaires that are done online, and for some of our older participants, they've struggled to do that online. The majority of them have preferred to fill it out face-to-face by interview, and that just means it impacts the type of tools that we can use for measuring these outcomes. But they have been, many of them, particularly the De Jong Grief Hod Scale and the Lubbock Social Network Scale, have been validated in a number of populations globally. And so when we look at what factors affect people's social isolation and loneliness, there are some very obvious factors around an absence of an intimate partner, the size and functioning of family relationships, particularly child and parent bonds. But we also see if people are participating in volunteer work or clubs and church, that they are less likely to be socially isolated and lonely. There are personality traits which increase or decrease the risk of people being socially isolated, gender and health as well. We also need to think more broadly around access to services and how that impacts people's feelings of social isolation. They may have caring responsibilities, which limits them from making connections outside of their home, insecure housing, disability, and financial stress. So all of these factors feed into impacting people's ability to make social connections. And so there are things that we can do at multiple levels. We know that it affects morbidity and health behaviours negatively, and it increases a risk of a number of chronic diseases, but also mortality quite significantly. But there are things that we can do at different levels of prevention to try and target and reduce the impact of this. So at an individual level, we can work with people to work on cognitive behavioural therapy or social skills in around training, around social skills and social environments. At a community level, we can support community engagement through volunteering, intergenerational programs, like I mentioned before, and also with our built environment, looking at, do we have adequate transport so that people can move about the town or the city and go to their community events. At a societal level, we can increase the awareness of social isolation and loneliness. Obviously, it can be a very hidden problem because people in their homes who are socially isolated and lonely are probably not really advocating broadly in the community about their experience. So we could do a lot around educational campaigns. We need government policies to really strongly prioritise the importance of social connection and working with communities to drive social engagement, and then having public and private funding to support the implementation and the evaluation of loneliness programs as well. I wanted to provide a little bit of context. I'm about to give an example of some of the work that we've done for an Australian setting. So I wanted to provide some context to that. In Australia, the majority of older adults live independently within their own home. They don't usually live with family, but they may be supported by their family and friends who may come into their home to provide social connection or to help them with meals or care needs, caring responsibilities, for example. But we also have government assistance. So there are people who are not able to access family and friends, and they have government assistance. At the moment, there are 273,000 people receiving government assistance in Australia, and they can receive this government assistance to help with personal care around activities of daily living, healthcare. Usually they have quite significant healthcare needs, transport, cleaning, gardening, food provision, and also social support. So obviously that's of most important for today's presentation. So they may receive funding to have a worker come to their home and to visit them, or to help them go out into the community and attend community events. So, for example, there may be a client who needs help only with one who needed help going to her sewing classes. And so the government provided funding to assist a carer to take her to her sewing classes so that she could continue that social interaction. And there are different levels of funding that are provided. So there are four levels of funding, and the greater your care needs or your healthcare needs are, the higher up the package you receive and the more funding that you receive to support you to live at home. And this is designed so that people can stay in their homes for as long as possible and delay them having to enter into any formal facility around residential care, which most people want to try and avoid. And the setting for the work that I'm going to speak about today is an organisation called Meals on Wheels. This is an organisation that provides meals for people who live in their homes but who no longer can cook for themselves, and largely are older people living in the community. And so it's run by volunteers. So each day meals are prepared in central kitchens all around suburbs and locations in the city, and then volunteers go and pick up the meals and then deliver them to older people in their homes. And they look something, this is just one example, but they differ every day, and they're provided, and the government provides financial support for this service. And so being that they visit older people in their homes, this organisation, Meals on Wheels, noticed that many of its clients were struggling with social isolation and loneliness. And when the volunteers were coming to drop off their meal or their lunch, the clients really wanted the volunteer to stay and have a chat and didn't want them to leave, because it was they were seeing someone in their home and they were having that social connection. So Meals on Wheels wanted to look at, well, how can we develop a service to support these clients to have more engagement with our volunteers? And this leads into the program, which I'll be spending the rest of the presentation on today, where we called it the Let's Do Lunch program. And it was a program that was run by Queensland Meals on Wheels and the University of Queensland and the Nutrition and Catering Institute in order to reduce social isolation and loneliness. And so that the aim of the program was really to see if we could impact people's social isolation and loneliness. So the intervention that we designed with Meals on Wheels was the clients were partnered with a volunteer, and every 3 to 4 weeks they went and would have lunch together in the client's home. So the volunteer would pick up an extra meal and they'd go in and have lunch together. The volunteers had training, which I'll speak about, to kind of have some casual discussions around clients' well-being. So they would talk about everyday concerns, but also checking in. We used this wellness wheel over here, where we asked the volunteers to ask things about their nutrition. Were they getting enough food? How was their physical health? Were they being social? Were they connected to family and friends? How were they feeling? Trying to understand a little bit more about the older person. And so the volunteer would complete these observations and then also report them back to the Meals on Wheels organisation, so that if that person needed additional support, that could be organised for them. So an example would be that a volunteer may observe that a client needs a new wheelchair or a new mobility support. And so they would report back that this person needed additional support, and Meals on Wheels could organise that support for them. And we had one person within this program who organised all of the lunches and the meetings. So we recruited volunteers and clients from across Brisbane in Queensland. We used a mixed methods non-randomised controlled trial, and there are a number of reasons that we did that. We delivered flyers to over 900 flyers to a whole range of clients, and people were able to self-elect to participate in either the control group and not receive any intervention, or they wanted to participate in the intervention itself. And we then needed to also recruit volunteers from each of the services as well to run the program. So the volunteers were trained. We did have to provide some training to support them to go into people's homes and have these types of discussions. And so we delivered the training at the services themselves. We created a workbook and a little educational video as well around how to not have a conversation, but how to maybe ask some questions in a very informal way. We didn't want the clients to feel like they were being interviewed. We wanted it to be very relationship-based. So we wanted to provide some guidance on how you might engage in that discussion. I don't know if I might just play a few minutes. I might just see if the sound is coming across, but please let me know if it's not.
Thank you for choosing.
Were you able to hear that?
Yes, Michaela, we can.
Oh,
Yeah.
okay.
But
I'll
now,
just play it.
yeah. Yeah, we can. But now it doesn't work. I mean, the sound is no sound.
Oh, there is no sound.
There is no sound. Yeah.
Okay, I'll just stop sharing and then I'll open it in the other way. One moment.
Okay.
Ah, there we go. Okay, I'll start. Okay.
Thank you for choosing to participate in the Meals on Wheels Let's Do Lunch program. Let's Do Lunch is a program that aims to offer an extended welfare check to our clients, alongside a social visit where volunteers have the opportunity to stay and chat over lunch. Let's Do Lunch benefits the client, the volunteer and the service in many ways. For our clients who may be affected by social isolation, it means more connection with our volunteers. Often we hear that we are the only people our clients see each day. We may also observe that a client needs more assistance when we spend more time in their home. For you as a volunteer, Let's Do Lunch allows you to learn more about the client and build upon the relationship you already have, whilst not feeling the pressure of having other deliveries to make. For the service, feedback and observation made while you have lunch will help inform the client's ongoing assessment to ensure we are providing the right support for them. Before you have lunch with a client, there's a few things you should be aware of. Prior to your lunch, your Meals on Wheels service will provide you with information relating to the client. You may already know the client from your current delivery runs, but it's important that you're aware of relevant information, such as client goals. So you're prepared to have lunch with the client, you'll be given.
So I won't show the whole video, but that's just the start of the instructional video that we developed to help educate our volunteers in the program. So the measurement tools that we selected for this project was the Lubbock Social Network Scale and the De Jong Greenfield Loneliness Scale to measure social isolation and loneliness. And these were collected at baseline and then again at the post-intervention mark for both our control and our intervention group. And like I mentioned earlier, the preference of many of the clients was to complete this survey face-to-face via an interview. So Jason, our coordinator, would go and visit the clients in their home to complete this paperwork. And so between the baseline and the end of the project, the intervention group had a number of lunches with their volunteer. And then the control group didn't have any. They continued to receive their food as normal. When we look at the numbers that participated in, when we look at the numbers that participated in the intervention, we had 41 people in the intervention and 95 people in the control group. Between the two groups, there was no statistical difference in terms of demographics, so that was a positive for our trial, and there was a similar spread around the age of the participants, and also their living status, their health rating, and how long they had been receiving Meals on Wheels. So it was fairly standard across both of our intervention and control groups. We did have a number of participants withdraw from the program. So when we're looking at the intervention group, we started with 41 people and we had 35 people at the end, which isn't too bad for a withdrawal from the intervention, particularly given this population. So we had some participants who had to withdraw because of their poor health, or they moved locations. Some of them, there was one that found that there was a burden associated with the surveys and didn't want to continue. But the majority of it was around ill health. When we look at the control group, we started with 95 and we had 75 participants complete their follow-up measurements at the end of the trial. The majority of people that did actually withdraw was either because they had passed away, they had poor health, they needed to move into a residential aged care facility, or they moved outside of the service or the location. So there was still some dropout in those groups. And when we look at the program delivery, so it was run across 5 months, and 136 lunch visits were completed by volunteers. So it was quite a significant number of connections that were developed. And we saw quite good continuations with 36 participants completing the first 3 lunches and then 27 completing a 4th lunch. In terms of the training, we had 9 volunteer training sessions, and we trained 44 volunteers to deliver these sessions. One of the challenges that we ran into, we would have liked the program to go a little bit longer, but it ran into Christmas, and everyone, usually around Christmas, a lot of people have family and friends engagements and are really quite busy. So we had to end the program just before Christmas. So the results from this project, we averaged the change in scores of social isolation and loneliness between pre and post measurements. And so when we look here, this is the De Jong scale on loneliness. An increase in 0.57 is a positive increase. And what we saw was that the intervention group did improve more so than the control. However, the difference between them wasn't statistically significant. What we then looked at for our analysis was a subgroup analysis of people who were identified as socially isolated and lonely at the beginning of the trial, because it makes sense that if you're not socially isolated at the start, you're unlikely to improve on your social isolation through this program. So we looked at those people who scored a 2 to a 6, which indicates some level of loneliness, and then those who were a score of a 5 or a 6 who are highly lonely. And again, we saw greater improvements in the in the intervention versus control, and more significant improvements when we look at these people who were highly lonely, an improvement in a score of 2 versus a 0.57 in a whole population. But again, it wasn't statistically significant. And one of the reasons that we suspect that this may have been the case is because by the time we were getting to the subgroup analysis, the numbers, the N values were quite small, and it's very challenging to see a statistically significant figure at these levels of N values. When we look here at, this is our social isolation score. So again, an improvement. So we saw an interesting relationship where we saw basically the score stayed the same for the control group, but decreased slightly for our intervention group, which was an interesting finding. But when we look at those who scored a 12 or lower, these are the people that are at high risk of social isolation. And so what we saw there was an improvement of 1.5 versus an improvement of 0.48 in our control group. Again, not statistically significant because we had very small N values, but what it did show is that potentially the people who, what it identified was that potentially the people who were the most socially isolated and lonely benefited the most from this program. And what we really need to do is to look at a larger cohort of participants who are identified as socially isolated and lonely to understand that relationship. But overall, it was a positive impact on people generally. It was a mixed method study, so we also completed qualitative interviews with our participants and with our volunteers as well, to understand their experience of the program. And I won't go through all of these themes today, but I'll go through a few of them. So for our clients, our older people in their homes, there was some initial anxiety around meeting new people, which makes sense. I think all of us can probably feel a little bit nervous when we're meeting a new person or a new group. But what they found was that they were able to gain a friend and develop a deep connection with their volunteer. So these here are some of the quotes from our participants. Some of the things that they really enjoyed was being able to meet new people with different life experiences. So there were some volunteers that we partnered with our clients who were potentially 20 or 30 years younger. And so they really enjoyed having that different experience and newer discussions. And we saw that the clients were, the majority, or all of them actually, were really enjoying the program. It was nice. They enjoyed having the company and someone to talk to. And it was lovely to really see people treat it like an event, and some people would set up a teapot and cake and biscuits and treat their volunteer. It was a real social event for them, which was really positive. There was also a lot of interesting through the thematic analysis that we did around how people perceive loneliness and social isolation. And when we think about these concepts, we usually think about chronic loneliness and social isolation, so over a long period of time. But what we found with our participants was actually that they had sporadic feelings of these rather than more of that chronic experience. So they gave the example that they may see their family a couple of times a week. So they have that connection, but there's still a couple of days where they don't see anybody. And in those days, they feel lonely. And that was really interesting, particularly from a measurement perspective, because we were trying to measure their overall loneliness and whether or not that really accounts for the sporadic nature of these feelings. We're not sure that the tool was able to capture that. So that was really, really interesting. We also found a number of people were hesitant to use the term loneliness or socially isolated. They didn't necessarily want to discuss that topic or felt a level of shame or stigma associated with being lonely or isolated. So what we often saw in the discussion was that participants would talk about other people being socially isolated or lonely and not themselves, or they would downplay their own experience. So they would say, oh, I'm lonely sometimes, but I'm not as lonely as my next door neighbor. They're really lonely. They have no one to visit. So they were very reluctant to use these terms when speaking about themselves. So again, that has implications for how we measure social isolation and loneliness, because if we're asking people to rate their feelings and there is a stigma associated with these concepts, it's going to be harder for us to measure. Looking at the volunteer feedback, we did have a number of volunteers that withdrew from the program. And this was because they were either unwell or they were traveling, they had to care for a family member. But the program was enjoyed by the majority of volunteers. It was challenging to sometimes match up our volunteers and our clients together. So there were some people that wanted to speak to a particular gender or an age group. They had particular preferences around lifestyle and background. So it was a bit challenging to match up our volunteers and our clients together. And interestingly, we also saw our volunteers' perception of loneliness differing to the reality. So sometimes our volunteers would go and see the client and think, they're not lonely, they don't need to see me. But actually the client felt lonely and they wanted to see the volunteer. And so when we had this, this mismatch between the experiences of the volunteer and the client, that was really challenging because the volunteer, felt like they didn't have any impact but actually the client really loved having that connection. They just didn't want to talk about their social environment. So the lessons that we learned from this program was that measuring loneliness and social isolation is very, very challenging. There was generally a reluctance to use the label lonely. People didn't want to attach that label to themselves. And so they often downplayed their experience or spoke about it in terms of other people. And the experience of loneliness was also more sporadic than it was chronic. We did have some interesting interactions where participants' actions didn't always match their words. So, for example, we would have participants that would say, "I'm not lonely. I'm fine. I don't need, or I'm happy with my social connections." And then our research assistant would go and visit them, and they would set up again a teapot and cake and biscuits, and our poor research assistant would be there for hours because they just wanted to talk to somebody. So it was an example where they wanted that social connection, but when they answered on the forms, they weren't eager to speak about that on their forms. So our next steps for this program is to run it in a larger scale. This was run in Brisbane, but we would like to run it across the whole state of Queensland. We'd like to look at targeting people who are specifically have high levels of loneliness or social isolation, so identifying them, and looking at running the program over an extended period of time, so greater, probably looking at more of a year would be ideal. And looking at also recruiting a particular type of volunteer, because there were some volunteers who found the workload to be too much. And we also found that there were some volunteers who were really good at the program. So retired healthcare workers, for example, were really, really strong volunteers in this program to look at engaging them. That is really the end of my presentation, to really show you an example of an intervention that has tried to improve social isolation and loneliness, and also the global context in which these concepts are situated as well. Thank you very much for having me, and obviously I'm happy to take questions now, but if at a later date you do have any questions, please feel free to email me and to reach out.
Okay. Thank you so much, Michaela. For your presentation. I would like to have a brief summary with maybe in Indonesian. So it will be more clear. Jadi tadi sudah disampaikan oleh Dr. Michaela tentang social isolation dan loneliness, ya, tentang kesepian dan isolasi sosial, dan bagaimana itu berdampak kepada kesehatan, ya, dan juga nanti berdampak pada gizinya, berdampak pada physical dan mental health, dan mengurangi quality of life, kualitas hidup, sehingga dan juga akan berdampak pada nanti morbiditas dan mortalitas, ya. Maka sebaiknya juga pemerintah, misalnya government, itu mengadakan program, ya, untuk bagaimana mereka tidak merasa kesepian dan merasa diisolasi, ya, terisolasi sosial, baik pada lansia ini, ya, terutama pada yang 65 tahun ke atas ini, ya, kalau di Australia. Nah, ternyata intervensi yang dilakukan itu cukup banyak, tetapi biasanya pada small scale, ya, dalam skala kecil, ya. Dan juga ternyata perasaan sepian itu ternyata tidak hanya dialami oleh lansia, terjadi, bahkan ini terjadi di semua umur, ya. Mungkin ini juga sudah mulai terlihat, ya, sejak setelah pandemi di Indonesia juga ternyata banyak juga yang kaum muda itu masih muda, ya, tapi sudah merasakan juga, ya. Jadi ada loneliness itu ada dua tipe, maksudnya dua aspek yang dilihat, yaitu apa sih loneliness dulu? Loneliness adalah negative feeling ya of missing relationship. Jadi perasaan negatif yang terhadap kehilangan hubungan ya, kehilangan hubungan dengan orang lain. Ada emotional loneliness dan juga ada social loneliness. Jadi ada kehilangan. Emotional loneliness itu misalnya kehilangan partner ya, kehilangan pasangan hidup, kemudian juga kehilangan teman dekat ya. Kalau social loneliness itu hubungan dengan eh, teman-teman ya, dengan tetangga, dengan hubungan dengan orang banyak, dengan yang lain. Itu yang social loneliness. Nah, kemudian social loneliness ini ternyata bisa diukur ya. Loneliness score itu lebih subjektif ya. Tapi social isolation itu lebih objektif dan bisa diukur, isolasi sosial. Nah, isolasi sosial ini diukur dengan labor social network score ya, ada scoringnya yang bisa mengukur isolasi sosial ya. Kemudian juga kesepian. Loneliness itu bisa juga ada scale-nya yang mengukur itu, De Jong tadi ya, ada beberapa nanti. Faktor apa yang mempengaruhi bisa terjadi loneliness itu adanya em, partner ya, kemudian ada hubungan dengan kegiatan-kegiatan sosial ya, ada hubungannya dengan kesehatan juga, kesehatan seseorang, kemudian personalitinya dengan apa kepribadiannya, kemudian dengan jenis kelamin ada hubungannya juga, hmm, kaitannya ada hubungan dengan eh, orang-orang lain ya. Nah, dampak kesepian itu akan berdampak pada morbiditas dan eh, perilaku perilaku kesehatan ya, dan itu juga akan berdampak pada mortalitas. Maka pendekatannya harus dilakukan supaya jangan sampai lansia itu mengalami eh, kesepian ya tadi. Di dalam Australian setting ya, di dalam kondisi di Australia itu ada personal care ya, jadi ada pendekatan-pendekatan yang dilakukan untuk menurunkan ini tadi ya, loneliness and social loneliness dan isolation ya, atau isolasi sosial maupun kesepian ini. Pemerintah sudah mengadakan personal care, health care ya, juga transport, acara, kegiatan-kegiatan cleaning, gardening ya. Jadi ada social support, ada dukungan sosial untuk membantu masyarakat yang lansia yang merasa kesepian ini. Dan itu ada level-levelnya, ada yang membutuhkan basic care saja, tapi ada juga yang sampai high level care. Ya, kemudian juga sudah ada program Meals on Wheels ya, jadi masyarakat lansia ini dikunjungi satu persatu, diberi makan setiap hari ya, eh, oleh volunteer, oleh sukarelawan atau relawan, dan mereka itu ternyata mereka merasa kesepian dan juga relawannya ini mengajak bicara ya, karena supaya tidak terjadi isolasi sosial dan kesepian ini. Kemudian UQ, University of Queensland itu juga mengadakan program Let's Do Lunch program. Nah, ini jadi kegiatan ini sekaligus juga research ya, eh, untuk meneliti bagaimana pengaruhnya ditemani. Jadi ada risetnya, relawannya itu datang untuk menemani makan siang bersama-sama setiap 3 sampai 4 minggu sekali. Ya, 3 minggu sekali dikunjungi, diajak makan bersama itu tadi lansianya. Ya, kemudian sebelumnya dilatih tadi, volunteernya atau relawannya itu dilatih, kemudian mereka diajak mengunjungi ya, secara sukarela. Kemudian diukur isolasi sosialnya dengan tools tadi ya, dengan Laben dan De Jong score tadi ya, kesepian dan sosial isolasinya seperti apa. Ya, kemudian diukur setelah, sebelum dan sesudah ya. Ini memang non RCT ya, jadi bukan, tidak random ya, memang tapi dari 41 yang diikuti ya, jadi ada 41 partisipan yang di kelompok perlakuan dan 95 orang di kelompok kontrol pada awalnya, tetapi akhirnya di akhir studi ada 35 yang kelompok intervensi dan 75 di kelompok yang kontrol ya. Setelah itu setelah dilakukan, oh ya, ini mixed method ya. Tadi ada kualitatif dan kuantitatifnya. Dan dampaknya ternyata skor loneliness dan skor isolasinya itu meningkat. Keduanya meningkat. Dan terutama yang meningkat adalah yang sangat merasa kesepian ya, dan sangat terasa terisolasi, itu yang mereka merasakan manfaatnya dari kegiatan ini. Dan dari hasil kualitatif ternyata didapatkan mereka ada yang nggak mau disebut lonely ya. Mereka tidak merasa kesepian. Kalau ditanya mereka nggak kesepian, nggak. Tapi tetangga saya yang kesepian. Ya, dia jadi mengungkapkannya itu orang lain yang merasa kesepian. Tapi tetangga saya itu lebih kesepian daripada saya. Jadi karena kesepian itu mungkin dianggap juga sebagai apa namanya, sebagai stigma ya. Jadi mereka nggak mau disebut merasa kesepian walaupun sebetulnya dia merasa sepi. Jadi kadang-kadang dengan kualitatif ini kita mengetahui bahwa skor loneliness itu nggak bisa dipakai begitu saja ya. Maksudnya karena ada perasaan bahwa dia nggak mau disebut lonely. Jadi kemudian kejadian kesepian ini adalah terjadinya secara bukan kronis, tapi sporadik. Jadi kadang-kadang dia merasa seperti itu, tiba-tiba merasa. Jadi kalau scoringnya itu secara kronis bisa jadi tidak dirasakan secara jangka panjang, ya. Kemudian action dan words itu ternyata bertentangan, kadang-kadang bertentangan ya. Dia nggak mengatakan merasa sepi, dia merasa tidak butuh teman, tapi dia berperilaku ternyata diajak ngobrol bisa lama sekali. Dan dia menyediakan biskuit, berarti dia sangat menikmati berteman itu ya, dikunjungi itu sangat menikmati. Jadi berarti berbeda, walaupun dia nggak merasa dikatakan dia tidak merasa kesepian, tetapi ternyata dia menerima volunteer ini, menerima relawan dengan sangat baik dan sangat menikmati dikunjungi itu, sehingga berbicaranya jadi panjang. Nah itu saya singkat ringkasan dari saya. Silakan kalau ada yang bertanya. Mungkin ini ada pertanyaan di chat, di kolom chat. Michaela, have you seen the chat box ya?
Yes, I
Yeah.
have. I'm happy to answer those questions.
Okay. Yeah. Yes. Please answer.
Well done, Martha. That was a lot to summarize. So well done on doing that.
Yeah, sorry.
But I'm happy to answer this question. So the first question I can see is, are there any group gathering facilitated for clients to get together and have meals between themselves after doing so? That's a really great question. So we did, before this program began, we did have a version which brought our participants together to have meals. And we trialed that a few times, and it definitely was a beneficial, or it was a positive experience. Some of the challenges that we had in running that program, though, was the transport. So all of the participants didn't drive anymore, and they couldn't walk to a central location. So we had to organise a bus that could take wheelchairs and walkers and mobility aids and go and pick all of the participants up. So this made it quite challenging to do across a number of areas and locations. But I think in the future, what we will look to do is do a combination of both this example that I've shown today, and then coming to have people come together for meals as well. The next question I can see is social isolation and loneliness something you can self-diagnose, or do you need an expert? No, it's something that you can do yourself. So you can either self-administer the questionnaires or a researcher can administer the questionnaire. So that is a good thing. You don't have to be qualified to do that. The analysis, it can, depending on the tool that you use, there is a little bit of analysis involved, but it's not overly complex. And the second question, in Indonesia, we have a culture gathering to eat, and so they're pretty social. Is there any chance that social isolation and loneliness could happen now? So that's another really great point, and it's something I'm really interested in around how culture is protective of social isolation and loneliness. In Australia, we are very much a multicultural population, with around 50% of our population born overseas. But as a society, we're not very collective overall. So I definitely think that it is protective factor of social isolation and loneliness. There's probably still going to be a risk as people age and become less able to engage, but I think there's definitely a protective factor there. And also a question around technology and social media. And that's a really good question as well. What we're seeing is people are connecting in different ways. Our older adults, some of them are really good with technology and using social media, and then some are not so good. So it depends on the skills of the older person. But we see a lot of people are now starting to connect online. So I think it has a benefit, but there still are a number of people who want to see a person in their living room or in real life and have that connection with as well. You can see there is another question. Yeah, that's it. So the two-part questions. How did we choose the volunteers? So in this iteration, we allowed anyone who was interested to be a volunteer. They just had to be able to give up their time once every 3 to 4 weeks and participate in the program. In the future, I think we would look at targeting a particular type of volunteer, because to be able to engage with conversation and feel comfortable talking with people, you need to have a level of, you need to be a little bit outgoing. And so we need people who have kind of those skill sets. So we look at recruiting those people. And how do we determine the lunch menu? Again, so Meals on Wheels organises this menu. They collect all of the preferences of everybody, and they develop a menu with a chef and usually a dietitian, and then help design that menu and deliver it. It doesn't mean we always get the preferences right, because like you said in your comment, everyone likes different foods. So there's some food people don't like, but generally most people are fairly happy with the meal that they receive. And thank you very, very much for your comment there. We hope that we'll receive funding to continue to develop this work in the future as well. I think that's all of the questions, Martha.
Yeah, thank you, Michaela. But maybe some of you, for the students and all the college who would like to ask directly, it is possible too. You can use Indonesian language or English. Siapa lagi yang mau bertanya, silakan. Boleh dalam bahasa Indonesia ataupun dalam bahasa Inggris. Tidak langsung juga boleh, silakan yang mau bertanya. Michaela, about the Meal on Wheels, is it available all over Australia or yeah?
It is. So it's actually an international organisation. So it's available all across Australia, in both our urban or city centres, but also in our rural and remote areas as well. And it's also available in the United States of America and many places that Europe, around the UK, Scotland and Ireland. So the Meals on Wheels is a very big organisation.
Mm.
And it's all run by volunteers.
The funding is from the government, or?
Yes, yeah, that's right. So the funding is from the government to support the staff, but without the volunteers providing their time free of charge, the program wouldn't exist. Interestingly, what we see with our volunteers is we classify older adults as people over the age of 65. But interestingly, a lot of our volunteers are also over the age of 65. So we usually see people volunteering between that 65 and 75 age group. And then between that 75 and beyond, they actually become clients of the service themselves.
Okay.
Yes.
But the volunteers are mostly on also in older adults.
Yes, they mostly are, yes. Because the meals are delivered at lunchtime, if you have a job, it can be very hard to take a break and go and deliver a meal. So most people are retired that volunteer. We do have some people who are students who may have work placements that volunteer, or we sometimes see mothers who have children that are going to school and have a time in the middle of the day when they can volunteer, but it's mostly older adults.
Okay. Yeah, so they have time to do that, right?
Yeah, that's right. I would love to see a program that's done at nighttime so that other people could volunteer. If I think about myself and my colleagues and people my age, we would love to volunteer to go and have dinner with somebody, but I can't go at lunchtime.
Yeah. How about the problem of the menu? Because older people mostly maybe they don't have any more teeth or something. Yeah. So did you also the food provided is also like considering that aspects too? Yeah.
Yeah. So the menu is designed to be nutritionally adequate for older adults. So we increase the amount of energy and protein in all of the meals. And then for older adults who have difficulty with chewing or swallowing, we developed pureed or texture modified meals. So these were meals that were softer and easier for them to consume. So depending on what they needed, they received the meal that matched their requirements.
So they are all different, have different.
Yeah.
Menu.
That's right. So it can be challenging to manage sometimes.
Yeah. Yeah. And how about the requirement of the energy? It's maybe also different between each other. So
yeah, it can be. We kept it the same across for all of them. We just increased the amount of protein and energy because generally in this group we see them not consuming enough. So we just increased the amount for everybody.
Yeah, but this is only for the lunch. How about the dinner and breakfast? They have to provide themselves. Yeah,
that's right. Yeah, there are some organizations that can deliver multiple meals. So there are some that you can order a breakfast meal or a dinner meal, and that can be delivered as well. But the majority of them is just lunch.
How about all the people that are sick? For example, they need food that very by Sunday or by other way.
So if they had significant health requirements, we weren't able to cater to really significant health concerns. This was, but we didn't actually have very many that were engaged in the program this time around. But if they needed assistance with eating, the volunteers weren't trained to do that. They were more there for the social aspect.
Okay, please, the students or at the college, would you like to ask something?
Okay, Prof. Marta.
Yeah,
Okay.
yeah,
May I ask to Dr.
yeah.
Michaela?
Please.
Dr. Michaela, good afternoon. Hello.
Hello,
Yeah.
yes, lovely.
Yeah. Okay. Based on the result of your study, how to monitor the condition of the elderly beside using the tools, questionnaire, or how to monitor?
How can we measure without using tools?
Yeah.
Yeah. It's very challenging to measure without the tools. There are different in Australia there's one question that we can use to talk to people about social isolation and loneliness, but it's very hard to measure without those specific tools. But what I did find was that the interviews were very insightful into people's experiences. And I'm a qualitative researcher. That's my favorite type of research. And so being able to hear people's experiences, I think, was really important. And provided a lot of information, but without the tools, it can be very hard to measure it objectively.
Thank you.
Okay, I can see
Yeah.
another question. Thank you, Irene, and a really, really great question around, involving older people. And that's a lot of the area of my research, and I probably didn't go into a lot of detail, is around co-designing with older people. So engaging older people in the design of services and programs. In this program, we had a group of older people that we worked with to develop the program. So they told us what they wanted. They reviewed the tools that we measured. And for example, we originally selected another tool and they reviewed that and said, that's too long. We won't fill that out. And so we had to change based on their feedback. So we engaged older adults in this program, but there is a lot more work that needs to be done to engage older people in the development of these services, and ensuring that we meet their needs and their preferences and that people feel empowered in that process and not like the research is just happening to them. So it's definitely something that needs to be strengthened. But yeah, we did involve that. We did include that in this work. I find it's really important. I hope that answers, and I hope that answers that question. But there's always more that can be done.
Oke, Irene sudah jelas. Irene Yunita Prihandini. Yeah, thank you for the answer, Dr. Michaela.
Bu Marta,
Ya.
mungkin Bu Marta bisa meringkas jawaban dan pertanyaan itu.
Ya.
Oke.
Ya, jadi dari pertanyaan pertama, ya. Mungkin ada lagi yang mau bertanya, silakan. Ya, mungkin dari Bapak Ibu ya, mungkin di Indonesia kita belum banyak ya yang mungkin tertarik untuk riset di maaf ini untuk riset di lansia mungkin nggak bisa si baterainya. Nggak masuk ya. Ya. Mungkin ada yang tertarik untuk riset di lansia, jadi ini banyak memberikan insight ya, bagaimana melakukan riset juga pada lansia. Jadi mungkin juga ada yang nanti tertarik ya melakukan penelitian pada lansia, bukan sekedar pelayanan di rumah sakit, tetapi juga pelayanan di masyarakat ya. Jadi saya ringkaskan ya pertanyaan-pertanyaan tadi. Mungkin ada yang menanyakan ada any group gathering facilitated ya tadi. Jadi ada memang layanan untuk gathering ya, mereka dikumpulkan, dijemput dengan bis begitu ya. Walaupun mungkin ada masalah ya, mungkin ada sebagian yang harus menggunakan kursi roda, ya itu dilayani ya. Jadi kadang-kadang juga ada kegiatan gathering di mana semua lansia ini yang dilayani diundang untuk makan bersama ya. Kemudian apakah tadi ada pertanyaan apakah di social isolation and loneliness kan bisa didiagnosis sendiri? Apakah harus membutuhkan expert keahlian khusus? Tadi sudah dijawab bahwa ternyata scoring tadi ya dengan pertanyaan kuesioner tadi, kuesioner De Jong dan kuesioner apa tadi yang disampaikan itu bisa ya digunakan tanpa Laben score tadi ya, bisa juga digunakan walaupun kita tidak expert di situ ya. Di Indonesia memang kita punya itu ya, punya kebiasaan makan tidak makan asal kumpul. Nah ini ya itu merupakan upaya yang baik ya di Indonesia, ada kegiatan ada seperti itu ya. Kemudian ada pertanyaannya bagaimana memilih volunteer, bagaimana volunteer dipilih ya. Memang volunteer itu jadi bagaimana mereka biasanya justru yang tertarik itu ya yang seumur itu tadi ya, yang usia 65 ke atas yang juga juga lansia ya, tapi mereka lebih muda 65 sampai 75, kemudian 75 ke atas biasanya jadi klien. Oke, kemudian ya public policy bisa how can public policy facilitate the active involvement? Jadi memang memang tadi polisinya itu didesain ya untuk mengurangi ya sosial isolasi tadi dengan dikunjungi ya, dikunjungi, diajak berteman ya, diajak apa bicara begitu ya. Oke. Ya, silakan. Pertanyaan-pertanyaan mungkin juga ada yang bisa dijadikan ide untuk penelitian Anda. Ya, silakan. Dr. Michaela, would you like to add some more, for example, the short message, maybe for the next or yeah.
Anything else I'd like to say?
Yeah, or would you like to also share maybe a topic of research that the students can be done in Indonesia or yeah.
So there's a range of areas that you can explore, and I think someone, Irene, has already said, looking at engaging older people as agents in the development of these programs and implementation. I think there are in Australia, we have particular populations who are at greater risk, and there's ideas that you could explore with identifying people within your own communities who are at high risk of isolation. So I've just put forward an application to the Queensland government, for example, to explore social isolation and loneliness in older women specifically, and those who live in rural settings. That project, if it's funded, will be led by older women themselves, and it will look at using examples such as interviews, but taking photos and qualitative ways of understanding information to identify the strength of their community connections and to how we can build those into the future as well. So there's a lot of work around different groups. I also think there's a lot of areas or a lot of work to explore the connection of family and also the connection of people from different ages. So how can we connect younger and older people together in different settings to support relationships? In Australia at the moment, we have, and globally, there are challenges with ageism and people perceiving older people in a negative light. And I think connection between younger people and older people would help that. And so programs that look at facilitating that would be another area that could be explored. And I mean, from a nutrition perspective, my background being a dietitian, I'm very interested in how loneliness impacts the types of food people eat or the types of food they don't eat, because when they are lonely or socially isolated as well. So there's many areas that could be explored as a research topic related to this, to social isolation and loneliness.
I'm sorry that Michaela, I'm sorry that there is a trouble in my laptop and with out of power. Yeah. Okay. Thank you very much for your presentation, and your experience in this area is very interesting and valuable for us to get information about this and maybe also give an insight to the students to have topics for their study, their research. So yeah, we appreciate your speak today. Yeah, very much. We appreciate your work also. Then hope that you can continue your work in this area and have a success on that. Yeah. Yeah.
Thank you very much, Mother. Thank you to everyone for your questions and for viewing the presentation. And yeah, hopefully it's inspired some people to complete some research projects around this topic. Thank you very much.
Okay. Thank you very much. For the students, maybe don't forget to fill out the forms. Ya, jangan lupa isi absen ya semuanya untuk bukti kehadiran Anda. Terima kasih. Thank you, Michaela, and thank you for all of the participants today for the visiting lecturer. We will close this meeting. Yeah. Thank you for all the participation and thank you for Dr. Michaela. Yeah, Irene, Yunita, would you like to say something? Yeah. Thank you for everything, for your coming. Yeah. Hope that we can have good insight and can continue to our work here to do the work in all the people in Indonesia. Yeah. di Indonesia kita banyak menghadapi problem ini juga ya pasti ya, di Indonesia banyak juga sekarang lansia semakin banyak dan banyak problem juga ya yang belum mungkin kita jangkau sampai saat ini ya. Jadi silakan Bapak Ibu yang tertarik untuk riset di bidang ini juga sangat menarik dan juga tentunya bermanfaat bagi bangsa Indonesia ya, yang kita juga hargai lansia kita makin meningkat dan mereka juga memerlukan perbaikan ya, memerlukan mungkin juga banyak yang mengalami sosial isolasi dan kesepian. Sekian saja. Ya, bisa pengembangan. Ya, untuk mahasiswa Simkas juga bisa ya, mereka Anda bisa semua juga bisa bagaimana memantau ini, memantau lansianya ya, dengan sistem informasi yang bagaimana supaya bisa terpantau dengan baik. Ya, baik semuanya, kalau tidak ada lagi, wassalamualaikum warahmatullahi wabarakatuh. Salam sejahtera buat kita semua. Sampai kita bertemu lagi di 2 minggu mendatang, ada lagi guest lecture ya di jam yang sama. Ya, selamat berjumpa di lain kesempatan ya. Selamat siang semuanya. Juga terima kasih untuk Bapak Wakil Dekan yang sudah membuka tadi. Sampai bertemu ya semuanya. Saya pamit undur diri. Terima kasih.
Kota Semarang merupakan wilayah yang strategis secara geografis. Dengan penduduk yang heterogen, Semarang memiliki keberagaman sumber daya manusia dan potensi lingkungan yang mendukung bidang keilmuan. Terletak di kawasan Pusat Pendidikan Tinggi Kota Semarang, program studi Magister Kesehatan Masyarakat Universitas Diponegoro melaksanakan proses pembelajaran bermutu.
Halo semuanya, saya Dr. Anda Ayun Sri Admi MKes. Saya adalah Ketua Program Studi Magister Kesehatan Masyarakat Universitas Diponegoro. Saat ini program studi Magister Kesehatan Masyarakat telah memiliki 5 konsentrasi, yaitu konsentrasi administrasi rumah sakit, konsentrasi administrasi dan kebijakan kesehatan, sistem informasi manajemen kesehatan, kesehatan ibu dan anak, dan konsentrasi terbaru yaitu gizi kesehatan masyarakat. Saat ini, program studi Magister Kesehatan Masyarakat Universitas Diponegoro telah terakreditasi oleh LAMPTKes dengan status akreditasi unggul.
Kesehatan masyarakat memiliki peran penting dalam upaya peningkatan kualitas sumber daya manusia, penanggulangan kemiskinan, dan pembangunan ekonomi. Maka dari itu, Magister Kesehatan Masyarakat Universitas Diponegoro menyusun kompetensi lulusan berdasarkan standar kerangka kompetensi nasional Indonesia. Selain mengutamakan suasana akademik yang kondusif dan lingkungan kampus yang nyaman, kegiatan belajar mengajar menerapkan sistem offline maupun online sesuai era digital saat ini, seperti adanya kelas hybrid dan smart class. Selain itu, gedung MKM Undip mengutamakan kebersihan dan keamanan.
Kami menyediakan fasilitas dan suasana akademis yang nyaman bagi setiap mahasiswa kami untuk dapat bimbingan, diskusi, atau bahkan berkonsultasi dengan dosen. Silakan dipergunakan fasilitas tersebut Yang penting adalah mahasiswa kami merasa nyaman dalam belajar dan proses belajar mengajar bisa berlangsung dengan sukses.
Mahasiswa Magister Kesehatan Masyarakat Universitas Diponegoro mendapatkan fasilitas-fasilitas yang menunjang proses pendidikan, seperti koleksi buku dan akses jurnal online. Serta ramah terhadap teman-teman difabel dengan menyediakan jalur khusus hingga fasilitas umum. Tak lupa, ramah juga terhadap ibu hamil dan menyusui maupun yang sedang sakit. Di luar kegiatan akademik, program studi Magister Kesehatan Masyarakat Universitas Diponegoro juga mendukung mobilitas mahasiswa dengan fasilitas sepeda kampus serta pemberian pengetahuan dan keilmuan yang dikemas secara modern melalui channel podcast.
Kami dalam hal ini termasuk rumah sakit pendidikan di Undip dan sudah menyelenggarakan berbagai macam aktivitas pelayanan dan termasuk pendidikannya. Kami menyediakan juga untuk MIKM mahasiswanya untuk bisa melakukan residensi, magang, dan juga kalau perlu nanti bisa kami rekrut di Rumah Sakit Nasional Diponegoro.
Proses belajar mengajar serta kurikulum yang komprehensif ditambah sharing alumni Magister Kesehatan Masyarakat Undip membuat saya semakin paham bagaimana harus mengimplementasikan ilmu manajemen rumah sakit dalam praktik sehari-hari sebagai Direktur Medik dan Penunjang Medik Rumah Sakit Santa Elizabeth Semarang.
Saya bersyukur dan sangat bangga sebagai ahli Magister Kesehatan Masyarakat Undip, peminatan administrasi dan kebijakan kesehatan. Proses pendidikannya sangat menarik yang didukung dengan fasilitas sarana prasarana yang sangat menunjang maupun dosen yang sangat kompeten merupakan hal yang menunjang keberhasilan kami dalam menyelesaikan pendidikan.
Mari bergabung dengan kami, program studi Magister Kesehatan Masyarakat, Fakultas Kesehatan Masyarakat Universitas Diponegoro.